Okay, thank you very much and welcome to today's session. My name is Dr. Lydia Omwansa Atambo. I'm a medical doctor and public health specialist. Today we are excited to have a team from DNDi and the GOK to come to talk to us about neglected tropical diseases. And the topic for today is the diagnosis and treatment with a focus on the challenges and the role of drugs for neglected tropical diseases. As we all know, NTDs are a significant cause a significant health burden in Kenya and Africa at large. These diseases disproportionately affect the most vulnerable populations in the region with a very high incidence and prevalence rates because of factors like lack of access to clean water, poor sanitation, and inadequate health infrastructure. In Kenya specifically, NTDs are a major public health concern with a prevalence rate of over 50% spread across the various diseases, meaning that more than half of the population is at risk of contracting at least one of these diseases. And the situation is similar across Africa, as the region, which is the sub-Saharan region, accounts for a significant proportion of the global NTD burden. Now, January 30th, which has just passed, was the World NTD Day, a day that serves to increase awareness of these diseases. Focusing on tackling NTDs is crucial for us, for the population, and for the health community, especially in Kenya. Firstly, NTDs have severe health consequences. As we all know, it leads to chronic disabilities, reduced productivity, and even death. This takes a toll on individuals, families, and communities, affecting the overall well-being and the social economic development of a community. But most of all, NTDs perpetuate the cycle of poverty. They hinder economic growth by limiting individuals' ability to work and participate in income-generating activities. By targeting the NTDs, the health system can help break this cycle and improve the quality of life for the Kenyan population. Today, we have with us our colleagues who will discuss this topic in a more in-depth manner. To start with, we'll start with Dr. Borna Nyaoke. Dr. Borna is a medical doctor with a Master's of Public Health from the University of Liverpool. She also attended the GCSRT research training program at Harvard, specializing in the conduct of clinical trials. She's the current head of Mycetoma at DNDi. That's the Drugs for Neglected Diseases Initiative, which is the main partner that is supporting this event. We also have Dr. Martin Chege, medical doctor at Kacheliba, serving as the Kacheliba Sub-County Hospital Medical Superintendent. They've done a lot of work with DNDi. There's a collaboration that they have. They have done medical camps, mass screenings. They've even had a charity marathon running for the neglected patients. And the collaboration that they have really focuses on Kala-Azar patients. Next, we have Dr. Cherinet Adera. He's a medical doctor, again, with a Master's in Public Health specialization. He's the Senior Market Access Manager at DNDi, Africa Regional Office, Nairobi. Thank you very much, and we welcome our guests to today's session. And so we'll quickly jump into the questions, and I'll start with Dr. Borna. So what is the burden of disease in Africa and specifically in Kenya? And also, while you're at it, discuss the most prevalent neglected diseases in the East African region and why this is happening. Why is the disease burden so high? Karibu, Dr.
Thank you so much, Dr. Lydia. So as described, neglected tropical diseases are actually a very diverse group of conditions. So people usually tend to assume they are caused by one specific pathogen, or they have this particular association in terms of transmission or management. But we do understand the disease is mostly put together because of the term neglect. So as you already mentioned, these are diseases that affect our poor communities, and most of these are within our tropical areas. So it is neglected does not mean that it is rare or we have very few cases. We actually have more than 1.7 billion people across the world who are affected by what we call neglected tropical diseases. 40% of these are within sub-Saharan Africa, and almost 25 million of these are within Kenya alone. The World Health Organization has designated 21 neglected tropical diseases in their WHO NTD list. Does not mean there are any, those are the maximum number which are available, but those are the ones which have been recognized and prioritized by the WHO, including Noma, which was just added in December of last year, Mycetoma, which was added in 2016. So within Kenya, out of these 21, we have almost 16 of these neglected tropical diseases within the country. Apart from the ones that we work in at DNDi, including visceral leishmaniasis and mycetoma, I'm sure which we'll talk about quite more. Others, I'm sure the rest of our colleagues have dealt with, including sleeping sickness, dengue, chikungunya, trachoma. We have intestinal worms, which is actually added as part of the NTD list. We have bilharzia, jiggers, rabies, chikungunya, trachoma. So we have quite an extensive list and quite a number of these NTDs within the country. But due to the fact that they're neglected, we tend to assume that they're not there within our communities because we are not paying attention to these particular neglected populations.
Thank you very much. It's quite alarming that we have 16 out of the 21. I think that's an alarming statistic. Cherinet, Daktari. So what are the main challenges faced in diagnosing neglected tropical diseases in Kenya, and why?
Okay, thank you, Dr. Lydia. As it was previously stated, neglected tropical diseases affect poor part of the community. And when we see health-seeking behavior of the community, especially in very remote areas and also poor part of the community, it is usually limited. Additionally, the time between symptoms, development of symptoms and treatment seeking is prolonged, which can have impact on the diagnosis of the disease. Additionally, when we think of the capacity, there is inadequate diagnostic capacity of neglected tropical diseases due to, for example, the nature of the disease in prevalence. If we, for example, consider leishmaniasis, especially the visceral form of leishmaniasis, one of the diagnostic methods is splenic aspiration. And as you know, splenic aspiration might not be performed everywhere due to different constraints like capacity of healthcare workers, even all materials which are required to do that diagnostic test. Additionally, infrastructure-wise, sometimes there are some molecular tests which can help in confirming neglected tropical diseases, but they are not easily available. And some of the diagnostic methods are also invasive. You cannot just, for example, in case of leishmaniasis, if there was a more effective diagnostic method which can just replace invasive procedures like splenic aspiration, the advantage could be high. And there is a variability in the sensitivity and the specificity of some of the diagnostic methods. And you might not use some of the diagnostic methods at periphery level. So referral level of health care is important.
Yeah.
Thank you.
So what I hear you saying is that there's the diagnostics tests differ in terms of specificity and sensitivity, which affects the quality of the tests. And some of these tests are quite complex and might not be carried out at the peripheral centers. So Chege, Daktari Karibu, so how accessible are diagnostic tests for neglected tropical diseases in Kenya? How accessible are they?
I hope I'm audible. Can you hear me?
We can hear you, Daktari.
So the neglected tropical diseases are quite a myriad of them. In West Pokot and Baringo, the one I largely take care of is leishmaniasis. the visceral type as opposed to the cutaneous. However, there are some that span from the coastal region, filariasis, chikungunya. There are areas that have schistosomiasis around the irrigation basins, Ahero and Moyatebere. And what the government does through MOH and partners is that they accord different regions different diagnostic aids to help them with care of these patients. Where I work, the government ensures I have right from rapid test to lab-based tests that aid in the care and accessing care to these neglected patients.
Excellent.
Back
Is
to you.
that true for all the neglected tropical diseases, or is that specific for Kala-Azar?
All right. So special mention to me is that Kala-Azar has an elaborate program where partners have come in to ensure both diagnostics and in terms of drug work is taken care of. But looking at the burden of NTD in Kenya, where we're discussing 16 to 18 of the 20 mentioned to occur within our borders, all being present either through testing or confirmation, there's still a lot to do. There's still a lot to do. Leishmaniasis at least has a structure, both shared by the partners and the Ministry of Health, where diagnostic and lab resources are available. However, I'm looking at things like snake bites and envenoming and other less talked about neglected tropical diseases, and it's a worst case scenario.
Yeah, some of them are missing. They hardly have some of those diagnostic tests. So Borna, Dr. Borna, we're back to you. So what are the main treatment options available for neglected tropical diseases in Kenya? Are we using tablets? Are we using vaccines? What's happening?
So dependent on the causative organism for the particular neglected tropical disease, this is what would determine the treatment. If we go into a disease like Mycetoma, this has both the bacterial and the fungal forms. So going back to also the question where you're asking about the diagnostic challenges, because first of all, you need to make an accurate diagnosis. If a patient presents to you and you have the clinical presentation of mycetoma with the sinuses and the grains, you still need to be able to conduct culture or molecular diagnosis of these grains to be able to determine this particular causative organism. If it is bacteria, then you put the patient on the antibacterial medication that is prescribed for it, or if it's a fungal infection, for most of the patients, we put them on itraconazole. So the difficulty also comes in terms of the treatment itself, apart from the diagnosis. If you look at sleeping sickness, where we've conducted the studies in DRC, there is sleeping sickness within the country, but not as endemic within Kenya. We find the patients who are on melarsoprol. And you could hear when patients were being provided this medication, they would say that they would feel like there's fire in their veins when they have these injections done because of just the severeness of the effects of these particular drugs. So the main issue that we usually experience with neglected tropical diseases is the treatments are not up to date. They're not current because these are poor neglected populations. We find the research and development component for the treatments are not as developed as all the other diseases that we're quite aware of, even other tropical diseases such as malaria or tuberculosis or even HIV. So the challenges are in the treatments that are available in terms of, first of all, they might not be safe. Second of all, they are not as efficacious. For mycetoma, the fungal form of mycetoma, the patient has to take 2 tablets twice a day, every single day, for a period of 12 months. So looking at the cost of the drug, which makes it very difficult for the patient to be able to afford it. And then second of all, compliance. Because we usually say even prescribing a 1-week antibiotic regimen to a patient, they are highly unlikely to finish it. So when you put this same for a patient for 12 months, we find that compliance is quite low, then the cure rates are also quite low. If you look at visceral leishmaniasis, for the longest time, the patients also had to come and stay within the clinical area so that they can be getting their daily injections. So if a person is a farmer or a herder or is just the breadwinner within the family, if they imagine having to be away from their family for 3 weeks, then they do not come for the treatment. So being able to provide oral, safe and efficacious drugs that are accessible and affordable to these patients is one of what we can say the treatment availability that would make treatment of neglected tropical diseases quite possible. So of course, the treatment ranges per what is causing the disease, from viruses in dengue and chikungunya to parasites to fungi in Mycetoma. So depending on the particular pathogen causing it, we have different treatments, but the challenges are more or less the same. The affordability, the safety, the efficacy of the drugs because of lack of progress in research and development.
Okay, thank you very much. So Cherinet, are there specific challenges in providing treatment for neglected tropical diseases, especially when we are talking about the remote areas of Kenya? Dr. Borna has sort of alluded to that in her answer, but what else can you add?
Okay, thank you. Generally, when we think of the drugs for neglected tropical diseases, most of them are donated. You cannot get them freely. According to WHO, normally, currently, there are around 18 medicines which are donated to WHO by manufacturers. Some of them are freely available in public, just suppliers, including KEMSA, but you might not find some of them because they are not easy to find due to factors like costs. So availability is one of the issues. Even in remote areas, the supplies might not be there whenever they are needed. Additionally, the toxicity of drugs, if we consider anti-leishmaniasis drug, one of them is sodium stibogluconate, which is given intramuscularly, and patients might develop life-threatening toxicities like cardiotoxicity. So if there were safe drugs, that problem could have been solved. The other thing is some services, not only drugs, but also services like hydroxylaser surgery, for example. There are waiting according to the NTD master plan. There is a long waiting list and long waiting time to get that service. So generally, these are some of the challenges. Thank you.
So there are more challenges seen with the more peripheral health facilities. So Dr. Chege, now that you're representing the government, so my next question is, what role does the government play in supporting the diagnosis and treatment of NTDs in Kenya? What's going on, and how is the government really coming in to see that these diseases are really contained and our patients get the treatment that they need?
Thank you for that question. We all belong to the government. There's very minimal that can be done away from the government. And therefore, last week, precisely 7 days ago, we launched the Kenya Master Plan on neglected tropical diseases. That's to run 2023 to 2027. That has major pillars. Pillar activities revolving around accelerating program actions. An example being, if you look at all the neglected diseases, some will require medication, some will require chemotherapy, some will require supplies. So these are infrastructural investments that the government has created a framework of which partners can hop onto and of which the government is strengthening. Maybe just to touch on maybe a simple exercise like MDA. That's mass drug administration. We've seen it being done periodically, but this is to regions which have been mapped out for specific NTD. Example is a chikungunya and trachoma. We've seen this being done by the government. Another thing would be the involvement in ensuring stocks are accessible to government institutions. If you look at the caregivers of these patients, they're usually hospital, which are public hospitals, largely because Cherinet has spoken about it. The cost of being able, for example, to administer for 17 days sodium stibogluconate and paromomycin for a patient with visceral leishmaniasis is quite expensive. It's quite expensive, and therefore the government ensures that at the time when this patient is diagnosed, we are able to move and escalate care. Another pillar is strengthening through according human resource. People don't don't per se realize how expensive it is to, for example, get a doctor in a small sub-county hospital like Kacheliba. Kacheliba is arguably 500 kilometers away from Nairobi, and we've had one doctor mopping a region of 140 kilometers, which is full of sandflies, and that's where the hub for leishmaniasis takes place. Therefore, the HR proponents, supply chains, pushing, and also creating awareness when to the masses, so that people are able to know what are the symptoms for example, lymphatic filariasis, or what are the symptoms for or how different is a fever for leishmaniasis and how different is a fever for the common tropical malaria. These are ways the government has done. The government as well has also created an environment that allows an organization like DNDi to venture rightly into drugs, get into studies, use public institutions to run study 1, study 2, study 3. We are actually about to roll out oral medications, which are going to, breaken the time you use to treat leishmaniasis, the cost, the ease of drug administration, and this is what the government has been able to do. Finally, is they are they are very fast in being able to roll out new drugs, especially the ones that have WHO has approved, and issue guidelines to various regions on how to go about this. So the government is upbeat on this. Maybe since I'm still speaking on the government, just to highlight the need or the budgetary allocation need to hasten our realization or pushing most diseases from a from a diagnosis to elimination. As of now, the only disease we've been able to eliminate is that famous poster that is on most clinics, where if you get a patient with a guinea worm, the reward is 100,000. That means you're pushing. We've already eliminated that, and we have a few more in the second tier, and we hope to push as many like leishmaniasis into elimination phase. So yeah.
So thank you very much. It looks like the government is doing a lot, but there's also opportunities for public-private partnerships, I've heard you say, so that we work together and collaborate to increase the impact of the work that we are doing. So Dr. Borna, are there any opportunities for collaborations with international organizations, which will then improve diagnosis and treatment of NTDs in Kenya?
Definitely, and that is also the basis in which DNDi works, because apart from the product development that we work on, we usually say DNDi by itself, we do not conduct the clinical trials. That is, we do not see the patients by themselves. At the same time, we do not manufacture any of the drugs or the diagnostic tests. So collaboration is the core of the work that we do. We have noted, apart from in research and development, we're usually quite aware the financial and human capacity that is required to be able to conduct a clinical trial. From the preclinical discovery up to phase 4 may take almost 10 to 15 years. Looking at that and seeing pharmaceuticals who might not have a financial incentive to actually work on a drug that might have to be sold at a very low price to be able to be supplied to these neglected populations, then it makes sense for organizations like us to come in to be able to assist them now in collaboration with teams like Dr. Chege, with the ministries of health in Kenya and in the countries that we work in, to have these particular sites where we're able to conduct the clinical trials with the molecules from these particular pharmaceutical companies. One of our biggest cases is with fexinidazole for sleeping sickness, where we were able to work very closely with the pharmaceutical companies. Apart from the research and development component, the other components such as diagnostics, we work very closely with FIND, which is a purely diagnostic company. When we look at a neglected tropical disease like visceral leishmaniasis or mycetoma, which, as we've already mentioned, is quite complicated in terms of the diagnosis. If we are able to provide treatment, it would not make a huge impact if the clinicians on ground are actually not able to diagnose this patient to be able to provide this treatment. So we need to be able to work very closely with them so that even as we work on the treatments, we are able to develop in parallel point of care diagnostic tests that would ensure that the clinicians on ground have all the ammunition to be able to actually manage these patients properly by being able to diagnose them properly and also to be able to treat them with the drugs available. Then we have other advocacy groups together, organizations like End Fund, where we've been able to also have quite good collaborations, because apart from treatment, diagnostics, prevention is also a very huge component, because with NTDs and the poor communities, we have to think about water, sanitation, hygiene. We need to talk about prevention of these particular diseases. We need to talk about community sensitization, and also just for the communities and patients to be aware of the diseases. So it is a multi-stakeholder initiative to be able to combat this disease, because as mentioned, it's not specifically the disease, but the populations that we're dealing with.
So collaboration is the game that we should be focusing on. No? Exactly. So Dr. Chege, So Dr. Chege, are there any potential threats or limitations to the diagnosis and treatment of neglected tropical diseases in Kenya? Are there any challenges that perhaps you have faced as DNDi?
I do not know whether Kenyans understand why these diseases are neglected. And I will not give you the most famous explanation. I will go back to some meetings which were held between 2003 and 2005, which looked at chronic infections which were characterized by certain geographic regions, especially sub-Saharan, whose quality was they would end up with an impoverished or a poor family unit afterwards. And that brought about the idea of neglected. And therefore, if you look at the spectrum of all the neglected diseases, the pattern is such that the people who have them, more often than not, do not know they have them, because they are, for one reason or another, either away from areas where they can get care, or they have some patterns like agropastoralism, or they just have a poor health-seeking behavior. And therefore, away from the usual structural difficulties, examples being impassable roads. We've had stories from Uganda, and that lower section where once it rains, you can't access healthcare, poor supply and linkage, electricity. So that being set aside, most of this medication, for example, I'll use leishmaniasis, has to be stored either within room temperature, 18 to 25 degrees. If you look at where Kacheliba is, it's on the northern belt, where it's a bit very hot. And that means we need to either think of an alternative source of electricity just to ensure that is upheld. The other disease like ambisome, amphotericin, it has to be stored in very almost freeze point. That means you need to run a freezer or you need to run an AC room at the middle of a Turkana or Baringo or West Pokot. So these are some of the hurdles which translate into high electricity bill for me as a hospital boss. And you see the number of patients you're taking care of is the minimal within the hospital spectrum. So for you to advocate and push for, let's say, an electricity pay for medication where you'll only use on less than 300 patients or 500 patients within the year, then you really need to have the heart to understand what neglected tropical diseases are. Other shortcomings are such that sometimes you have stockouts, largely because for people who do procurement through KEMSA or KMEDS, you know, what you haven't used, then there is no way to track it down. Sometimes you're given even an antivenom to spend or to use, and then after the duration, you've not spent it, and therefore restocking you becomes a problem. But what happens when a patient walked in with a snake bite and all your stock is out? So these are the common problems you have that affect the care within this region. Other than that, we have poor household mapping or poor community diagnosis, and that would be a good way to come in. Since the discussion is around universal or UHC, it would be important to, as we are mapping households, to factor in these tropical diseases, rather these neglected diseases, and have them find a slot in that discussion. Otherwise, if you're discussing fever or malaria, you might as well throw in leishmaniasis or, you know, chikungunya right there, so that we take care of this unit as an item.
Thank you very much. I think you're giving us a very insightful look, you know, an area where sometimes you can be blind to the realities on the ground. Thank you very much. So Dr. Cherinet, what are the current realities in terms of the availability and affordability of diagnostics and treatments for neglected tropical diseases in Kenya?
Okay, thank you. Regarding manufacturers, most of the manufacturers of NATD commodities are either few or single manufacturers, which can have impact on the supply, which is usually limited. Additionally, the lead time, if you want to order a drug to a company, which is the sole manufacturer of one product, the lead time is extended. Sometimes it can go over 6 months. So it cannot solve the immediate need of either the country or a certain parts of the country. And the price in most of the NATD drugs is very expensive. That's why donors are also involved in covering the costs. Additionally, patients are not able to afford even the available drugs due to high costs. And when we see the demand, some of the NATDs, the burden is not clearly known, which means when we think of the demand, it is related to the burden. The demand is going to be low until you know the clear burden of the disease. Additionally, there are some complicated, some cases of NATD which are difficult to diagnose. Some of them, for example, get confirmed after traveling to different healthcare providers due to absence of the diagnostic methods in the remote part of the community where the burden of neglected tropical diseases is too high. When we think of funding, there is a donor dependence. And even if there is some sort of political will and commitment just for NTDs, it is not as equivalent as other diseases which are of high public health significance. There are competing priorities, and domestic resource allocation is not too much. I can give you one example of donor dependence. A few years back, UK8, which is one of the donors for neglected tropical diseases, decided stopped just provision of the fund for procurement of leishmaniasis commodities. At that moment, there was almost the visceral leishmaniasis control program across the globe, not only in Kenya or East Africa, across the globe was in danger, because WHO, who is usually procuring the supplies and providing them to the countries, was not in a position to get immediate, just immediate fund source, while FCDO or DFID decided to withdraw. The other thing is supply chain management. Sometimes the supply chain management, the patients might not get the drug while the drugs are available in central warehouse. And also there is a good initiative currently of developing standard operating procedure for NTD commodities, which is being done by the Ministry of Health. That can solve the issue. But currently, if we take example of leishmaniasis, it is not unlike other drugs which are distributed and stored by KEMSA. It is not part of the drug which goes to KEMSA. It is managed by the ministry directly. So the supply chain management issue sometimes can be difficult. And patients at the community level who are at risk of NTDs are usually very poor. They cannot afford the expensive drugs. And sometimes those community have poor access for healthcare services due to their way of, for example, if we consider population at risk of leishmaniasis, there is cross-border movement, for example, from Kenya to Uganda, from Ethiopia to Kenya, to border countries. So someone who acquires the disease in one of the countries, when goes to the other part of the country, might not get the proper service, and also political instability sometimes, and also migration can also have impact on overall NTD accessibility. Some of the NTDs also are also epidemic prone due to, let's say, arboviral diseases, for example, due to climatic change. We can see outbreaks sometimes, which is expected to have a challenge in ensuring proper access for diagnosis and treatment. Thank you.
Thank you very much. So sustainability, surveillance, and supply chain management are some of the key factors that are affecting how we manage the conditions. And is also thrown in climate change, which for sure really affects the incidence and prevalence rates of some of these conditions. So Dr. Borna, we are back to you. So we are talking about innovation. So how can innovative technologies and approaches be leveraged to improve the diagnosis and treatment of NTDs in Kenya?
So I usually go back to the populations because when we talk about diseases as they are, it's usually quite easy, if I may put it that way, to be able to look at tackling them, especially like if you're a healthcare practitioner. But then when we put the neglected aspect of it, that is when we do require to be a bit more innovative to actually be able to cater to these populations. Some of the activities that we've done, of course, as we talk about Kenya, a lot of our work is within the region and outside. So I will touch on also on some of the countries that we're in. If we look at Sudan, where we have, which is quite endemic for Mycetoma, and we have the Mycetoma Research Center, which is based in Khartoum. So before the current political situation, we were aware that the patients with mycetoma are not within the city. These are very far-flung areas in Sena and Jazira states, which are around 600, 800 kilometers away from the city center. So having these healthcare practitioners being able to travel there like every weekend or to identify patients had become quite difficult. So they were able to identify sites where they provided generators and some screens and have some local healthcare practitioners or community health promoters who identify patients and they bring them to these health centers. And through telemedicine, you would have these particular experts in mycetoma who would be able to actually provide virtual assessment of these particular patients, because you also do not want to take a patient over 600 kilometers and then are informed it's not mycetoma, it's podoconiosis or even cutaneous leishmaniasis. When you're able to have that fast screening, it helps them to be able to identify the best area to be able to actually have these patients in. This has also been adopted by the WHO, where they have developed a skin NTD application. This provides, it's free, anybody can be able to download it, and it provides you with numerous pictures of different diseases and specifically skin NTDs, so that it helps the healthcare practitioners wherever they are to be able to diagnose. It also has an option of you taking a photo of that particular lesion and sharing it with the rest of the experts who can be able to provide you with that diagnosis. I would find that very helpful, because if you look at Dr. Chege and team, if they're within these particular rural areas and they have been able to identify a patient with a particular skin NTD and they want to be able to have a better idea for referral or adequate treatment, it provides you with a very large resource without actually delving quite deep into the financial resources of logistics and also having the patient stay within a particular area for a prolonged period of time. There are also other areas where we've been able to see how technology has been able to help. Cutaneous leishmaniasis, also back to mycetoma, considering their skin NTDs. Some are quite superficial, some usually affect the subcutaneous tissues. We find we require quite a lot of imaging to be conducted. So the most common ones, of course, ultrasound, MRI can be quite expensive. We found that we've been able within our clinical trials to be able to use newer technologies such as the 3D scanning, which is portable. You're able to go with it to just a small machine that you're able to go with it within the field. And with that, it is able to provide you with a 3D view of this particular lesion within the patient. So that already makes it a bit easier in terms of management, so that you know, is this a mild lesion which is only based on the skin, or it is a moderate to severe where you can see some bone involvement, and this provides an easier way for you to actually be able to refer these patients for treatment. So of course, there's still quite a lot to be done, considering all the innovations that we've seen in health in the last couple of years, especially post-COVID. And NTDs are still far behind, but we're happy to see the little progress that has occurred. And of course, with facilities such as this, where we're able to have these discussions, the World NTD Day, and more advocacy being done for NTDs, we hope even the technology programs are able to also update their activities within the NTD space.
Excellent. So NTDs are catching up with technology in terms of AI and imaging. That's exciting. So next we will talk about, I think the last two items we'll talk about is pharmaceutical industry and R&D. So I'm going to ask Dr. Chege to talk to us about perhaps what's the role of the pharmaceutical industry in providing medications for NTDs in Kenya? What's happening? And, are they providing medication? Can they help to assist in the supply chain complications that we are seeing?
All right. Thank you for throwing that very big ball. Every time you discuss pharmaceuticals, there's always a financial proponent, which is the bigger proponent. Most people have veered away from diseases that do not necessarily translate into profits. And therefore, the burden is, or the task ahead is an uphill one. I wouldn't know how to discuss. An example is filariasis gives you something called a hydrocele that needs surgical intervention. So if you're looking at a patient who has had this condition and you're even able to accord, let's say, the oral medication to deal with the worms, there is a sequelae intervention that you need to do to take care of the surgical emergency. And that is not something you can pen a partner and say, we need this one done, because that is as per need arising. Not to divert from pharmaceutical engagement or involvement, I think Dr. Cherinet alluded that very few people are willing to go hunting where they're not sure of where to take the loot. So most have stayed away, and we are grateful to the ones who've been on course, the ones who've taken up this mantle. There are very few. They are doing a good job. Sometimes you sense malaise because you project, let's say in my small sub-county hospital, that we will get 1,000 patients, let's say in the entirety of West Pokot. And then at the end of the year, we end the year at around 800 patients for both Kacheliba sub-county and another satellite hospital called Sigor. And then you see, if it's a single pharmaceutical who was dealing with, let's say, that stock, then you can sense some fatigue checking in. In terms of whether there's a significant gap, I would say yes. I would be very happy to wake up to a day where all neglected tropical diseases have a partner who's actively involved in taking care of these patients. If you looked at how we set the climate, discussing matters of nutrition, matters of climate, matters of what do these people actually do, you realize there's more than just giving medication. I'll give you maybe the course of treatment for a leishmania patient, a leishmaniasis patient. It takes about 17 days, and that's on the active treatment, where they are jabbed on alternate buttocks, or it's called the upper-outer quadrants to most doctors, for 17 days. But before you begin the 17-day course, you need some interim time where you take them through the rapid diagnostic that could be as simple as an RK39. If that is inconclusive, or you're not very, very certain, or in the event that they have co-infection or other underlying comorbidities, then you might need to do an agglutination test within the lab. If these are either out of stock or not available, then you need to train a healthcare giver to be able to do a splenic aspirate. For most doctors, if you remember that capsule that covers the spleen, the speed at which you go in and out is rapid, and that is an acquired skill. So it's not for everyone. It's because the mortality that happens, it's a fully packed spleen that sometimes enlarges to levels of 28, 30 centimeters. And that means all the blood probably, or all the destroyed red blood cells are packed there. And it's a simple injury that could result in hemorrhage and loss of life. So back to pharmaceutical, I hope Cherinet will deal with R&D, research and R&D. In terms of pharmaceutical, I think we would want to see someone run probably with, let's say, leprosy or schisto, or someone else runs with the snake program. And DNDi solely probably deals with a few conditions, pediatric conditions, but the mainstream neglected diseases, if they all got a partner, we would be very, very we'd have a better direction.
So Chege, the gap is not only in pharmaceutical. You have given us so many gaps, and that's what you're saying. The gap is beyond the pharmaceutical gap that I asked about. Okay. So the last question we want to talk about before we open the session for for questions is, what opportunities exist for research and development of new medications or treatment approaches for NTDs in Kenya? How is the research process going? Do we have resources? Do we have human resource? And even after the studies have been launched, are we getting, positive feedback from the data that we are collecting? So I'll throw that to Dr. Borna as we close out the session.
So whenever you talk to anyone within clinical trials, we always say it is not enough. Because even as we saw during the COVID period, when we were having hundreds of thousands of clinical trials being conducted in the global north, we saw that within our global south area, we were well behind. And this just goes into the resources that are required for research and development. Apart from the finance aspect, because as mentioned, if you look at the life cycle of developing a drug, which may take from 5 to almost 20 years, this requires quite a lot of commitment. Then looking at the resources in terms of human capacity, because if we even talk to the doctors within this particular call today, how many actually have can we say, experience in conducting any research or clinical trials, apart from what was required for your thesis in your master's or in your PhD? We do not take part in research work. For most doctors or healthcare workers, research work is always put as a back burner as we try to make money, if I can put it crudely in that way. And also in terms of the resources that even our government or we prioritize in terms of concentrating on research work. So of course, there's quite a lot of work in Kenya that is currently being done. If we look at KEMRI, if we look at CAVI, ICR, if we look at quite a number of the smaller research organizations. But I usually say it also starts from us, because you speak to a particular doctor and they have a very interesting case report, but it has never been published or was not even written up in the first place, or there's no need to actually follow up on that. So if we're not able to start with the small that we deal with on our daily basis, then it becomes hard for you now to start thinking of how can we actually look for treatments of mycetoma that you rarely come across with. Or if you start looking at treatments for cutaneous leishmaniasis that you might never have to treat while you work within Nairobi. So we have quite a lot of let's say, reduced capacity in terms of the interest within the particular research, the resources that we put in conducting the research, and also the support that we're able to provide. Because apart from, let's say, looking at your master's in tropical diseases, we are unable to find maybe within the country specialization in terms of conducting clinical research or clinical trials. So those are some of the challenges which may prevent the advancement of R&D. Because also going back to COVID, because I feel it gave us quite a lot of learning points, we were able to see how we could get research up and running. Why we're not paying a lot of attention to NTDs. The NTDs do not affect the global north. It is not through sneezing and respiratory droplets. This is our disease. And we do not expect other countries to spend their resources to look for treatments for a disease that does not majorly affect them. So if it is our disease within our region, we are the ones who need to actually spend our resources to actually find the adequate treatments for these particular diseases. So I believe we can be able to find treatments, but we need to first of all identify the diseases, understand their burden, prioritize them, and also ensure that we put enough efforts in our R&D. And then maybe I'd leave for Cherinet to provide the access part, because he's the one whose expertise is in that.
Dr. Cherinet.
Okay, thank you. Regarding access for new drugs and diagnostic kits, there are different challenges. First of all, as Borna said, researches are usually sponsored by global norms, and local capacity is not as strong as the global norms. So utilization of evidences, translation of those evidences into policy takes time. And usually decision might not be taken, immediate decision for policy change might not be taken at the country level until the global community approves it, which is one of the challenges. The other thing is even registration of drugs, for example, new drugs. The manufacturers, which are usually single, are not interested to register their drugs because it is not profitable. The population which are at risk of diseases in different countries are limited. For example, if we take one disease in Kenya, the demand which comes from Kenya is not satisfactory from the manufacturer perspective to bring the drug, new drugs, and get it registered, which means registration by itself is also one of the issues. The other thing is for new drugs in the diagnostic kits, sometimes the type of studies which are conducted do not involve certain group of community. Let's say for pregnant women, we know that there are drugs which are teratogenic. So if there is no other option, a study should be conducted to provide the proper treatment for those group of population. But since there is no evidence, the decision to treat certain group of community is going to be challenging. Additionally, multi-sectoral collaboration. Usually, the research unit which leads the study is somehow different from the policymakers. If there is active engagement of the policymakers with every research, especially clinical trial and neo-diagnostic methods, translation of that evidence to policy will be smooth. Thank you.
Thank you very much. So from this discussion, we found that there are so many gaps that exist within the NTD space, but beyond that, that there's opportunity for collaboration, and together we can move forward in tackling some of the challenges that have been highlighted. So we'll open the floor for 1 or 2 questions before we close the session. Anyone with a question? Yes, Bethan, kindly go ahead. Bethan Hughes, kindly go ahead. Kindly unmute yourself and then go ahead and ask the question. Okay, maybe you can type your question kindly. Okay, he's unable to sort out his microphone. Anyone else with another question, perhaps, as we are waiting for him to type?
I can see one online. Maybe if I can answer that.
Yes, please.
So we have one who's asking whether we partner with pharmaceutical companies. So specifically, yes, for DNDi, as mentioned, that is our core in terms of collaboration. Currently, the oral drug that we were able to deliver for sleeping sickness, feximidazole, was worked on in direct collaboration with Sanofi, where they were able to provide the molecules, and we worked with the local companies to be able to actually implement the clinical trials. For Mycetoma, with our clinical trial that we conducted at the Mycetoma Research Center in Sudan, for stravuconazole, which is the azole that was used for treatment, was provided by Eisai Pharmaceutical, that is a pharmaceutical company in Japan. So a lot of the work, as I mentioned, that we work on is dependent on the collaborations that we do, including pharmaceutical companies who usually have some of these drugs that we repurpose for the neglected tropical disease program that we find the particular drug works for.
Okay. Thank you very much for that. And Bethan has finally typed and he's saying he has a question for Dr. Chege or Cherinet about leishmaniasis care. So he's asking that apart from the 17 days of active treatment, what other care do patients with visceral leishmaniasis need when they're in the hospital setting?
Can go first. So yes, the biggest of things is to deal with their stigma and feed them. Your typical leishmaniasis patients, other than fever that has persisted for more than 2 weeks and an enlarged hepatosplenomegaly, they're usually normal, healthy people. And so you have to convince them to be in the hospital for their jabs that are given in the morning. And so they have a whole day to either be in the hospital or they want to sunbathe because of the injection site pains, and they can't lay on bed as well. Because by the time you're getting to day 12 or day 10, most of them are complaining of worsening pain in the back, and they do not want to lie supine. So they usually have that, and that means you need to work around how to feed them for 17 days. Number two, anemia is a key complication, either before care, because much of the red blood cells have already been sequestrated in the spleen. So they usually present with anemia. They need a blood transfusion, watch for reaction, and monitor them as you're doing the drug administration. Other than that, the medication themselves, the patients complain that they are very powerful, and we have to feed them and a high protein diet for these 17 days. Other than that, post-care, the other intermediate and maybe long-term complications, not all patients respond equally. Some patients have underlying comorbidity and co-infections, particularly, let's say, HIV, or rather being seropositive. And we look out for things like post-Kalaza treatment or disease treatment eruptions on the skin, PKDL. They're not very common, but when they occur, you also need to talk to the patient on their way home on how to watch out for them. Thank you.
So a lot to think about. Dr. Cherinet?
Okay, thank you, Dr. Chege. Thank you, Bethan. We can see leishmaniasis in different forms. About the visceral form, Dr. Chege has already mentioned. One thing I want to add is about different infections. When a person is infected with visceral leishmaniasis, he or she is predisposed to different infections due to suppressed immunity. Respiratory infections, for example, or gastrointestinal infections could be there. Patients require treatment for the specific infection, which is co-infection, which is identified. Additionally, malnutrition is common in Kala-Azar patients. So nutritional therapy is important. And there are other infections like tuberculosis and also HIV. HIV co-infection is common actually in Ethiopia. So unlike in the region, it is very common in Ethiopia. Those patients are at risk of acquiring multiple diseases due to the effect of both HIV plus visceral leishmaniasis. So comprehensive care is important. Even psychological care is important because visceral leishmaniasis with HIV co-infection is related to high risk of relapse. Almost relapse is inevitable in case of HIV-VL, and patients might require to come and admit to the hospital for repeated times. So they need counseling. For cutaneous leishmaniasis, it is stigmatizing, as Dr. Chege said. Sometimes, if it involves phageal area, students might not go to school. So, as part of the treatment, counseling plays a vital role. Thank you.
So thank you very much. Thank you to our panelists for this very eye-opening session. I'm sure we have learned a lot and have understood the logistics, all the work that is going on behind the scenes. And we are very appreciative of the work that you're doing. So thank you very much for joining the session and have a good evening.